Welcome to This Explainer. Today, we're diving straight into something that affects, well, literally all of us eventually. We are exploring the complex, deeply human ethical issues involved in caring for older patients. Specifically, we're going to be navigating the really tricky intersection of dementia and a person's autonomy. It's a delicate balancing act, figuring out how to protect an older patient without trampling on their fundamental right to choose.
Now, you might be wondering why this is absolutely crucial to talk about right now. Well, just look at the numbers. We are living in a rapidly aging world. Back in 2012, about 11% of the global population was over 60. By 2030, that's projected to hit 16%. And by 2050, we are looking at a staggering 22% of the entire worldwide population. To put that into perspective, that is over 2 billion people aged 60 or older. The sheer scale of this demographic tidal wave poses a massive question. How do we effectively and ethically care for our elderly without stripping them of their human rights?
And this aging demographic isn't just growing, it's completely changing shape. It's becoming incredibly diverse. For example, recent stats show an 80% increase in the number of people over 60 from Black, Asian, and minority ethnic backgrounds in England and Wales alone. So for healthcare professionals, this isn't a one-size-fits-all scenario anymore. They're navigating a super complex, evolving landscape where diverse needs, varying cultural expectations, and totally different family structures all collide right at the patient's bedside. Now, when we think about getting older, we often try to comfort ourselves with lighthearted sayings, right? Like that classic Mark Twain quote, "Age is an issue of mind over matter. If you don't mind, it doesn't matter." It's a fun, comforting thought that reinforces this idea that age in and of itself is kind of meaningless. It tells us that age is just a number and your mindset is the whole shebang. But yeah, sociological research completely shatters that rosy sentiment. The stark reality is so much heavier. As researchers Colasanti, Slevin, and King point out, in the 21st century, simply being stamped with the label old often strips individuals of their societal power. Old age isn't just a number, it literally becomes a social location in its own right, and that location can confer a total loss of power, completely regardless of whatever other advantages or privileges a person might have had earlier in life. So to combat this inherent loss of power and the very real issue of ageism, we have legal frameworks stepping in. Take the UK's Equality Act 2010, for instance. It explicitly makes age a protected characteristic, meaning you cannot discriminate against, harass, or victimize someone just because they've got a few more years on the clock. This sets a firm, absolutely non-negotiable ethical baseline for us. A patient's age should never, ever determine the standard of treatment they receive.
Let's bring this down to earth with a real-world scenario to see how these lofty ethical principles are actually tested in the trenches. Meet Angela. She's an 87-year-old woman who has just been rushed into A&E after a really bad fall. She's frail, she lives completely alone, and honestly, she knows she's going to struggle to cope by herself. Now, imagine you're her doctor. Your immediate gut instinct is to admit her. You want to keep her in the hospital for a few days, make sure she's safe, and figure out a proper discharge plan. But Angela is digging her heels in. She is adamant she wants to go home right now because she wants to maintain her independence. You know it's incredibly risky. She knows it's risky. So what do you actually do? This dilemma right here perfectly captures the ultimate tug of war in elder care ethics. It's a clash between respecting a patient's autonomy versus exercising what's called judicious paternalism. On one side, you have autonomy, the basic right to self-determination. It's literally the foundation of human life. If you trample on that, you destroy the trust that the entire doctor-patient relationship is built upon. But on the flip side, judicious paternalism argues that, hey, a patient in A&E might be in agonizing pain or distressed or confused, and that compromises their decision-making. Letting a purely autonomous but poorly thought-out decision stand could lead to a totally preventable disaster. But before we rush to just override Angela's wishes for her own safety, we really have to pause. Why is facilitating her independence so vitally important ethically? Is it more than just checking a box for autonomy? Oh, absolutely. Maintaining independence is deeply tied to a person's dignity. It's woven into their mental well-being and their fundamental sense of identity. Taking that away is huge. Legally and ethically speaking, though, before you can just accept Angela's refusal of treatment and send her back to an empty house, her refusal has to hit 4 distinct marks. Her choice must be fully informed, it must be completely voluntary without anyone pressuring her, it has to be an ongoing decision, and here's the kicker we're going to focus on, it must be capacitous.
Determining capacity is the absolute crux of this whole thing, and it's not some clinical guessing game, it's strictly governed by law. In England and Wales, we look to the Mental Capacity Act 2005, and over in Northern Ireland, there's the similar 2016 Act. These laws lay down the exact legal blueprints for making decisions on behalf of people who might lack the mental capacity to do so themselves. And these acts build in some incredibly heavy protections for patients. First off, capacity is always presumed to exist until proven otherwise. You've got to take all practicable steps to help a patient make their own decision. And get this, you absolutely cannot declare that Angela lacks capacity just because you think going home is an unwise move. Making a bad choice doesn't mean you lack capacity. Plus, you can't establish a lack of capacity simply based on her age, how frail she looks, or her general medical condition. So to actually legally prove a lack of capacity, there is a very specific sequence you have to follow. First, there has to be a proven impairment or disturbance of the mind or brain. Second, there has to be a direct causal link. And finally, it comes down to a functional test. You have to show that this exact impairment is what makes the patient completely unable to make this specific decision at this specific time. Okay, so how do we actually do that functional test? We check if Angela fails any of these 4 criteria. Can she understand the information about going home? Can she retain that info long enough to actually make a choice? Can she use or weigh that information? Like, can she balance the risk of falling again against how badly she wants to be in her own bed? And finally, can she communicate her decision? If she fails even one of these, she lacks the ability to make the decision. Now throw a condition like dementia into the mix and things get wildly more complex. This is where we bring in the concept of dynamic capacity. You see, capacity isn't just a permanent on-off switch. It fluctuates. A patient might have total mental capacity to make a really complex choice over their morning coffee, but thanks to fatigue or sundowning, they might completely lose that ability by the time the sun sets. They might be totally capable of choosing what to eat for lunch, but entirely incapable of consenting to major surgery. Because capacity is so dynamic, healthcare providers have to be incredibly careful about just blindly trusting an old assessment scribbled on a chart. And honestly, they need to look in the mirror too. The way a doctor explains things, their demeanor, and even the environment. Like, think about a chaotic, noisy A&D hallway versus a calm, quiet room. All of that can actually artificially influence whether a patient appears to have capacity or not. It's huge. We also can't talk about clinical choices in a vacuum. We have to zoom out and look at the broader societal context. In the UK alone, there are 2.8 million people aged 50 and over providing unpaid care. That's massive. When an older patient's autonomy leads to a really risky hospital discharge, the ethical burden doesn't just evaporate. It often lands squarely on the shoulders of disadvantaged families. It's usually unpaid, overburdened family members, very frequently women in their 50s, who are literally left to catch them when they fall. At the end of the day, providing truly ethical care requires treating the older patient with immense dignity. It means recognizing the subtle power dynamics in the room. Are they just nodding along and agreeing with you because older generations are often more deferential to doctors? Are their choices being unfairly swayed because they know they rely so heavily on their family's support? Navigating all of this, it requires deep empathy and incredibly active listening. So the next time you hear about a case like Angela's, or maybe you find yourself caring for an aging loved one, I want to leave you with a question to chew on. In our rapidly aging world, where conditions like dementia slowly blur the lines of capability, how will you balance that fierce human instinct to protect someone from harm with their fundamental, absolute human right to choose their own path? It's not easy, but we have to keep asking these hard questions. Thanks for joining me on this explainer.